I found out this morning that while we were lecturing yesterday, Sherry was in a wreck out here on 1417. Traffic was stopped and a truck ran into her from behind. So it's always something out there. Out down by the vet.
At the turnoff there.
Yeah. Yeah. Apparently the car is still sitting there. So. A little bit of housekeeping and stuff. I'll get into Canvas if Riley will remind me before we depart today. Do a little cleanup in Canvas, show you some things. I activated week 3. I failed to do that for you yesterday, and my apologies for that. So this PowerPoint's in there. But we'll just take a gander at Canvas and make sure we're all on track. I know some of you have turned in IS 100, and that's an easy grade for me. Don't judge me, but before church service, when they're doing announcements that has nothing to do with worshiping, I do my Canvas grading. So I did not do that Sunday morning. So it won't take me long to grade that if you turned it in. But, yes, sir.
When do we need to get, what do we need to get into Platinum for?
For your test next week.
Okay.
So we will, we'll make sure you can get into there by Tuesday, which is going to bring me to another announcement here in a second. So thank you for bringing that up. So we'll clean up Canvas. We'll gander, make sure we're all on track there. And then I had a question this morning from a concerned student who said, how do you know which chapter to go to in the textbook? I'm trying to read in order, and when I do so and I come in here, you're on a different chapter. The better way to do it would be to follow the modules in Canvas, and it will kind of lay out what we're going to do for the week. And I may make variations on that as well. If you have read your chapters, you notice they kind of start repeating themselves, or they're repeated in the other. I would love to see what the size of that textbook would be if we took out repeated things. I know where you're going. You just got to trust the process. That's hard to do. We like things in order. We number off 1 through 10. Why don't we go 1 through 10? Well, I didn't write the book, and I don't think they wrote it in a nice order as well. So bear with that process. I know it can be disturbing, but this is what works in the time frame that we have. Any other questions before I bring up the next subject? Okay, so Platinum and testing. There'll be 5 or 6 tests in this class. They're major exams. We mentioned the other day that if I give you a test, I waste a lecture day. We got 3 hours in here, and I promise there will be somebody who will take most of that time. I will start crunching down on time the closer we get to the end of the course, because the registry is timed. You just don't have all day to take the registry. And they actually have a clock of doom is what I call it. They have a clock up here in the corner of your test that's clicking down, and you're like, and you don't know how many questions you're going to get. So, it'll either cut off after a certain number of questions, it'll cut off after you've determined you've passed it, or it'll cut off after it's determined you failed it, or it'll cut off if you run out of time.
What tell you right then, man?
It'll just say, exam concluded.
When will we know?
Probably that day. If you take it in the morning, I know you'll know it by the end of business that day. If you take it late in the afternoon, it'll probably be the next morning. Now, the computer knows immediately. That's what turned it off most of the times. But it runs it through statistical analysis for verification. Matter of fact, they tell me that the computer knows within 10 questions if you're going to pass it, because it's an adaptive test. So we'll talk more about that as we get closer. Don't worry about the test. If you can handle the class, the test will be easy, okay? Okay? If you can handle the class, the test should not be a problem. Amber just got red and pale at the same time and put her hands down. You okay?
Oh, yeah.
Okay, good.
Is that the same format for the paramedic?
Uh-huh. Yeah, the paramedic test has different style of questions than the EMT does, but it's coming to the EMT as well. Yes?
Are we getting our CPR on Thursday? CPR certification. Nope.
Do you need it?
Yeah, I think because that needs to be into SurePath by Thursday.
Yeah, we won't worry about it.
Okay.
Yeah, I'll knock them around if they give you any trouble over that. I do cardiopulmonary resuscitation when I do cardiac chapter, and that's week 7 and 8, and it just really fits well right there. It'll be okay. The rule is you need it before clinical, so yeah. Thank you for the attention to that detail though, and noticing that there was something due that day, but yeah, I don't do it yet. CPR is almost like a no-brainer after you go through respiratory emergencies and cardiac emergencies. I'm going to teach the content here. You just have to do the skill, so not a problem. This Thursday, airway skills. Airway skills. Chapter 11, I believe, in your textbook is the airway maintenance chapter, and that's pretty much a skills chapter. And we'll talk about a lot of that here today. Any others? LMAs are an optional EMT skill. There is a section of the skills toward the end of this course where I do paramedic assist skills, because you guys will be assisting paramedics. So I'll teach you how to get the IV ready, draw up medications, manage advanced airways. But to your point, your medical director often allows LMAs for EMTs. But it's an optional deal for the EMT. All right, let's get going. We got just a little bit of time to get this knocked out. So, lucky for you, respiratory anatomy physiology has already been knocked out. So we're going to concentrate on specific diseases today of people that cause them to call in for a respiratory emergency. True or false? Respiratory complaints will be your number one EMS call. True. How much of the National Registry is based upon respiratory emergencies? A large percentage. The largest percentage of the exam is in respiratory. Why? Because that's your number one call. And what you see on the National Registry is kind of like, let's test them on what they're going to actually be doing out there. And as you move further down the test, the smaller portions, it just means you don't do much of it as an EMT. Once you become an EMT and paramedic, when you go up for renewal, you'll answer a survey, and it says, what is your most common call? What is your least common call? Rank this in order of importance. And so they actually base the exam off of what people in the field are seeing. And you're going to go take that exam, and you're going to look at something like, how do I manage a Portuguese man-of-war sting? What's that matter? I don't think we have those in Lake Texoma. Well, statistically, the majority of the population lives within 30 miles of the coast. You ever thought about that? Where are the big population centers in the United States? Within 30 miles of the coast. Well, obviously, as a whole, as a national level, we work a lot of marine type injuries and bites and stuff. So that's why that's on there. We'll spend a lot of time with this one right here. And there will be 3 categories today. And I want you to start thinking about those categories now. There is respiratory distress, respiratory failure, and respiratory arrest. Those are the 3 big umbrellas that we're going to work under today. And it's up to you as EMTs and paramedics to determine, is someone in distress, failure, or arrest? Now, you can have trouble breathing, but you're still maintaining oxygenation and gas exchange. You can go into respiratory failure, the exchange of those gases has started to fail. And then you can go into arrest, and that's the worst of all of them, you're not breathing. And you have to look at a patient, determine which one of those they're in, and treat accordingly. And then we'll go through how do we manage them. So we'll look at that. So this is where we start case studies. This is where I pick on a couple of people in the class and see where your knowledge base is so far, and then we'll go from there. Luke, let's just start front of the room today. Who would you like to run this call?
Yeah.
All right. You're up, Starrett.
Oh, yay.
Luke's your friend, isn't he? EMTs Jake Pratt and Paul Berg arrive at a residence to find 62-year-old Margaret Brown sitting at the kitchen table. She's only 7 years older than me, and for some reason she still seems ancient, so I guess that's a good thing. Leaning forward on her hands to breathe. Starrett, what are you thinking so far? I'm going to back out of that a minute. What are you thinking so far? She's leaning on her hands to breathe. Can you visualize that in your head?
Kind of. I don't know what that means. Like
So she's sitting at the kitchen table, leaning forward on her hands to breathe.
So is that like she's like this on the kitchen table?
Probably on her knees. Her hands are probably on her knees and she's leaning forward.
Okay.
We have a name for that, Jordan. It's called the tripod position. So if you ever hear somebody say she's tripoding, she's in a tripod position. Why would she be in that position? Give me some thought. Her chief complaint is what? Shortness of breath. Isn't that what it said? Oh, it didn't say that. So why do you think it's a breathing problem? Because you told me we were studying respiratory emergencies today.
Right now.
That's a good clue. I mean, I wouldn't fault you for that.
Maybe so she can expand her chest forward.
Yeah, she's kind of like just, I like to say they're biting at the air. They're trying to crawl over the air. They're gasping for air. And you'll find those people in those tripod positions. They immediately note that she is a thin woman with a barrel-shaped chest. We got any ideas what a barrel-shaped chest looks like?
You said tripod, right?
Tripod positioning.
Yeah, barrel-shaped chest is where like it's a lot thicker than it looks like it's supposed to.
The distance from front to back is just as much as it is from side to side.
Yeah.
You know, we got kind of an oval-shaped chest if you look at it from the top, but now it's barrel-chested. Any idea how it got that way?
It means it's probably filled with fluid or air.
It's been filled with air for so long.
Yeah.
It's been filled with air for so long, it's actually changed the shape of the skeleton, of the rib cage. I thought at the end of exhalation I got rid of all my air and took in new air. Well, I do, because I'm normal. You may not agree with me, but I'm normal. That means she never stops exhaling, doesn't it? Like she never gets rid of all of it. She goes to exhale, and she's so hungry for air, she inhales again before she exhales all the rest. So she kind of just stays what we call hyperinflated. For a long, long time. She's doing this while she sleeps. She's doing this while she tries to eat. She's doing this when she goes to the bathroom. She does this when she's carrying on a conversation. She does this all the time. Does that sound terrible to you? She's a thin woman. Gus? We're going to call you Paul. Why is she thin, Gus?
Because she's tired.
Well, kind of.
She's having to use all that force to breathe.
Okay, so exhalation has become active. So she's burning twice the calories to breathe. One respiratory cycle is now times 2. Plus, do you want to eat if you're going, I mean, some of you, Jonah, you're stopped up this morning. I mean, if you were trying to eat, you'd like have to pause and breathe for a little bit just because you can't breathe through your nose very well.
Like a baby.
Yeah. And she's using accessory muscles to breathe. So there's a lot in the assessment right there. And have you even touched her?
No.
Where did you do this assessment at?
The front door?
Love it. We call it the 30-foot assessment. I found out a whole lot about this woman without even touching her from 30 feet. I know a few things. She's having trouble breathing, accessory muscle use. And what accessory muscle use, while she's leaning up on those hands, on her knees, tripoding, and she's also pulling her neck. I mean, she's just trying to really expand this. You'll see the neck tug, the muscles in the neck will bulge out. You'll see the clavicles, the muscles around the clavicles try, and they may even flare their shoulders. They're just doing everything they can to expand that chest cavity. That's accessory muscle use. In pediatrics, we may see them, their belly getting really animated in its motion, because a baby may not be able to set up on its hands and tripod. They just may have to lay in the bassinet, if you will. I know a lot about this patient from 30 foot away, and I also know that whatever disease she's suffering from, it's chronic. So here we go. It's chronic. Is what position a good one?
Is the tripod position a good position to be in?
For her it is. For her it is. And what's one of our biggest things we do in EMS when we get them on the cot? We try to lay them down, don't we? Hey, if helping her to breathe, if laying down helped her to breathe, she'd already be doing it. So remember that, okay? That cot will raise up. Sometimes you can set their feet on the floor, and I'll tell you how that helps here in a little bit. But trying to put them on their back. I mean, I've taken nursing home patients who had blue skin and pulse ox in the 70s and take the pillow out from behind their head and set them up. They pink up, and like, you didn't have to call me if you would just gotten them out of this suffocating position. So yes, keep that in mind, the positioning. So the C stands for chronic. Chronic is the opposite of acute. What's acute mean? Short term, sudden onset, gonna leave. Chronic means you live with it. It's always there. I'm going to put an O in this word, and it's going to mean obstructed or obstructive. Chronic, obstructive. I'm going somewhere with this. Pulmonary refers to what? The lungs? The lungs and all the breathing stuff? Disease. Chronic, obstructive, pulmonary disease. From here on out, we will call that COPD. Stare it. Based on this scenario, does she have COPD?
Yes.
Because the shape of her chest tells me that she's been doing this for a long time.
I do have a question.
Uh-huh.
So when they become barrel chested, where is that air going? Because the lungs can only fill to a certain capacity.
Right.
Are they just expanding?
Right. So what happened to her tidal volume? What happened to her tidal volume? If you're not letting it all out, his question is, how do you get more in if you never let it all out? What's happening to our tidal volume? It's going down, isn't it? How will the body compensate for less tidal volume to make up for and ultimately get to more minute volume? Yeah, it breathes faster. So, Sarah, I'm going to anticipate her breathing rate's going to be faster than normal in order to compensate for the decrease in tidal volume. Right? That makes sense to everyone? But that's what I anticipate. So I'm not just going to write down 14 or 22 on the deal, am I? I'm actually going to do it, and I measure her breathing, and it's 7 times a minute, 8 times a minute. If you measured her breathing rate and it was 8 times a minute, what would you begin to think? She's crossed a line, hasn't she? She has went from distress to failure, maybe even trying to unlock the door to failure. Arrest. We would anticipate her to be breathing faster than normal, but if she's at 8, I'm really becoming concerned because she's tiring. She's wearing out. She's about to give it up. It really escalates the call real quickly, doesn't it? So we haven't been given that information yet, but you know what we would like to see, and maybe we will or will not see it. I love this descriptor of COPD. It's the devil's disease. It's the devil's disease.
Remind me what COPD stands for again.
Chronic, obstructive, pulmonary disease. And we're going to lecture on that here in a little bit, so don't get all messed up. I'm just playing with the scenario as we see it. It's often termed in the medical community as the devil's disease. Of the diseases that are out there, this is one of those that I would rather have that than COPD. I'd rather have that than COPD. At least that will kill me. What? Yeah, at least that one's quick. It's merciful. It'll kill you quick. This one will kill you. But it takes it can take a long time. And it's not fixable. Hence, it's chronic. It's not fixable. People who suffer from COPD never have good days. They just have some days that are worse than others. Okay? Please remember that. You're not going to make them well. Neither is a physician, neither is surgery, neither is the healthcare system. They're always going to suffer from this. They call you when today it's so bad they can't take it. Do you remember me speaking about sometimes I do a patient assessment before I ever get to the patient? Sometimes I do it through the dispatch call. If the dispatcher called me and said, we have a 62-year-old female complaining of shortness of breath. Caller states she has a history of COPD. And that's all the dispatch information I get. I'll automatically know something. She's having a really bad day. And it was so bad she called 911. And so you guys are going to get mad at people. You're going to get aggravated. You called me at 2:30 in the morning because you're short of breath, yet you smoke cigarettes. How am I supposed to have mercy and sympathy on you? You know? I've got a picture on my phone and I can't show it to you because it would identify a person. That would be a HIPAA violation. But it's a picture of a person who was wearing a nasal cannula. It's an oxygen device that goes up in your nose, and she smoked a cigarette and it just lit up her face. It burnt her airway. I guess I could blot out the eyes like they do and show it to you, but there'll be other pictures out there that have permissions. I don't have permission with this one. But it was sent to me by someone who said, you do teach your EMT students the dangers of patients smoking while on oxygen. Yeah, well, here's why. So when you walk in and see that stuff, you're going to be a little bit aggravated. Just remember, this person is always in a bind, is always struggling to breathe. How bad must it have been? Trust me, they don't want you at their house at 2:30 in the morning. But it must be really, really bad for them to call you. And you're not even there yet. So drop the anger, the frustration. I get it. I get it. I lost a father to cancer, but he also was starting to suffer from COPD, and I always got on to him about his smoking. But once you cross this line, there's no coming back. So if you're going to not get COPD, you need to stop smoking immediately. If any of you are smoking now, I hope this lecture will make you go throw it all in the trash, because it is the devil's disease, and maybe you'll see why in a little bit. Cool with what COPD is? And I know this girl, or this young 62-year-old lady, has it. So I'm going to start talking to her. I'm going to touch her. I'm going to get a history from her. I'm not going to plant COPD in her head. I'm going to let her tell me she has COPD. I don't give them the answers with my questions. In other words, I don't go up and say, Miss Margaret, I bet you have COPD, don't you? Because her short answer will be, yep. I mean, it hurts to breathe. It's hard to breathe, and I'm not going to spend a lot of time talking. She's going to give you what we call a one-word answer. I would probably go up to her and say, Miss Brown, what's your medical history? And she will probably get out, are you trying to say bronchitis? Yeah. Okay. Or she may say, probably more in this case with the barrel-shaped chest, the emphysema. Do you have emphysema? Is that what you're trying to say? Yeah, emphysema. Did you use your inhaler? Yeah, 3 times. Okay, it didn't work, did it? She used her inhaler. She's doing all this stuff and it's still not working and she's having a really bad night. Doesn't tell what time of day it is. We say she is having an exacerbation. An exacerbation of COPD. It just means she's having an episode that's worse than normal. And my job as the EMT or paramedic is to help her break that and get her back at least to what her normal is now, which is terrible. It's really odd. All I want to get you back to is terrible. Because I can't get you any better than that. Isn't that sad? Let's move on. Okay, stare. Despite an increased respiratory rate, we know why that went up, right? Trying to get the minute volume. And increased work of breathing, that's the accessory muscle used, the tripoding, the gasping for air. Her skin color is pink. Good? Bad? It's not blue.
Yeah, that's good.
Turn this off for a minute. Will you keep that for me? Don't let anybody get it. Don't let anybody get it. So if I got a red blood cell sitting over here, and on that red blood cell it has an iron-containing protein called hemoglobin, right? Hemoglobin. And hemoglobin has iron. Iron, like iron in your diet, like iron to make a plow out of, like iron as a component of steel. Like people who have iron deficiency probably have a hemoglobin issue. You got to have iron in your diet. Okay? And we'll be able to look at patients later and go, you're iron deficient. Whatever. Hemoglobin and oxygen love each other because of the iron. What do you do with a piece of steel out in the elements outside? It'll rust, won't it? What color is that rust? Reddish brown. What color is the hemoglobin? Reddish brown. You're rusting away. It's oxidized. So the hemoglobin loves the oxygen. And when you saturate the hemoglobin with oxygen, does it not become brighter pink, brighter red? And when it's not saturated with oxygen, it is a darker red. You with me on that? And maybe even with no oxygen at all, it's blue, and we call that cyan. Cyanosis, low O2. But she's not cyanotic, is she? It says she's pink. Are you happy? You are treading lightly. You're like, uh-oh, he's asking us a trick question because we're going to say, yeah, we're happy because she's pink. We have to be a little bit careful with that.
So will she just be having
Go ahead, Billy. Do what now?
confusion? That she's not having enough time to confuse because she's getting...
Okay, so I think your question, if I'm hearing it correctly, and correct me if I'm wrong, she's breathing so fast there really isn't time for the oxygen to diffuse across the membranes. Yes, that could be a problem because if I'm breathing shallow and fast, I'm never cleaning the lungs up. So yes, I can breathe so fast I don't get gas exchange because I never empty. Well, that's what she's doing every day, Billy. She's not letting the air get to the bottom because she's exhaling as soon as she inhales, and inhales as soon as she exhales. Shallow and fast, still got to get it to the alveoli. Otherwise, it's just in dead space, isn't it? Let me say this. Since she's COPD, she has much more dead space than you do, Billy. Because she's a COPD patient, she has much more dead space than you do. Depending on which form of COPD she has, she could have alveolar destruction. If she's got the other form of COPD, called the chronic bronchitis, her bronchial tree is so swollen and full of mucus, it doesn't ever get to the alveoli. The net result's the same. She's pink, though. If I threw a nickname out there that's common in COPD land, the pink puffer. There's another one out there called the blue bloater. Oh, these are medical terms, aren't they? The blue bloater and the pink puffer. You can be both. You can get a hybrid between a pink puffer and a blue bloater. Luke, you ready for me to flip your world upside down for a moment? Luke's like, go for it. Go for it. The RBC and oxygen makes it bright red, bright pink. Without it, it becomes bluish, more cyanotic. But this person's got an issue. Billy just told me they're not diffusing oxygen over to the red blood cells quite as well as they do in normal people. So why are they pink? Well, let me tell you why. Do y'all remember something from a week or so ago called chemoreceptors? And what do they measure? The chemicals in the blood. So there's the chemoreceptors that are in the blood that's measuring chemicals, and they're sensing chronic low O2 levels. They are sensing chronic hypoxia. Are they not? And oh, Margaret up here. Margaret's got chronic hypoxia, doesn't she? Because she has a chronic disease of the pulmonary system. Cool, Luke? So those chemoreceptors are reporting to the autonomic nervous system and going, hey, why are we still hypoxic? We've increased the breathing rate. We're using accessory muscles. We're breathing as hard as we possibly can. Why are we still hypoxic? And the autonomic nervous system says, I don't know, we're trying, but let me try this. The autonomic nervous system says, let me try this. It goes down here to the liver and says, hey, liver, can you help us out? Liver's like, what? We're having a really hard time breathing up here. We're having a really hard time fighting hypoxia. Is there anything you can do, Mr. Liver? The liver says, yeah, sure. Let me try this. I'll help you out. So the liver secretes a hormone. The hormone's called erythropoietin. Well, no kidding. You knew that, didn't you, Luke? You didn't know that? You didn't learn that? Now you know it. Secretes a hormone called erythropoietin. And erythropoietin goes to the bone marrow and says, give me some more red blood cells. We talked about this with the athletes training in Denver. Miss Margaret's not an athlete, and she's sure not in Denver. But the liver does the same thing. It secretes this hormone, and this hormone goes to the bone marrow, and the bone marrow make more red blood cells.
Can you remind me what hypoxia is?
Low O2. Just low O2. Hypoxemia, low O2 in the blood. Chemoreceptors see this as a chronic condition, tell the liver we need help. The liver tells the bone marrow, give me some more red blood cells. In essence, I have more boxcars on the railroad tracks now. Because if you can't fully saturate a blood cell, your next alternative is just give me some more blood cells that are partially saturated. And so she has an increase in RBCs per volume of blood. Can you say it like this? Her blood's thicker. It's more concentrated. It's got more particles in it than normal. Does this make her prone to clots? Does this make her prone to PE like we talked about yesterday? Pulmonary embolism? Make her prone to strokes? Make her prone to heart disease? Yeah. The answer is all yes. So she gets a bunch more red blood cells. That may be why she's appearing pink even though she's cyanotic. Kind of with me on that? It's kind of a false thing, isn't it? Now, blue's bad. But don't just assume pink is good either. Because I can assure you she's been producing many more red blood cells. And that may be why she's pink. The next part of that little catchphrase is puffer. So I'm going to watch her breathe. And if she breathes like this, let me back up because I'm going to exaggerate my breathing. You know what I'm doing there? We call that pursed lipped breathing. She is breathing through pursed lips. Pursed lips. She's puckering up when she breathes. She is putting some pressure on exhalation. She's not just going, she's actually putting some pressure behind it. That exaggerated pressure is keeping her alveoli open. Because her alveoli are so sick due to the chronic exposure of the smoke. If she's a smoker, could be a chemical, could be an industry thing, could be a coal miner. You get the picture. Her alveoli are being destroyed, and when they destroy, they collapse. She's trying to keep them open by putting pressure on her lips when she breathes out. We have a name for that, Jordan. The abbreviation is called PEEP. And that stands for, you ready? Positive end expiratory pressure. Positive end expiratory pressure.
It's just the letter P.
Huh? Yes.
Is she doing
Positive
that on purpose, or is that
end expiratory pressure. She is doing on purpose, but she's doing it subconsciously. It's really odd that the body knows to start breathing like that. Now, on our lab day, when we look at a machine called a CPAP, we're going to show you how to put a CPAP on a patient like her. And CPAP stands for well, don't bother writing this down right now. Continuous positive airway pressure. The CPAP creates some PEEP to help keep those alveoli inflated. But no, Jonah, she's picked this up. Her body just knows. So as I'm assessing her, I'm going to see if she's exhibiting pursed lip breathing. That would also make the barrel chest, wouldn't it not? If I always kept it tight. These patients do that to prevent atelectasis. Remember that big word from the other day? Collapse of the alveoli. Because in a COPD patient, once the alveoli collapse, they're gone. I told you about a tennis court size surface area under normal lungs. You just think about her losing tennis court. She may be down to a ping pong table now. Seriously. Every day she loses more alveoli. Therefore, every day she increases what kind of space? Dead space. The devil's disease. No wonder she's worn out. Don't let the pink say all is good. If it's an exaggerated pink, you don't expect her to be pink, do you? But she is. So why? Well, she's got a lot more red blood cells. That also increases her risk for some other things. What else is going on inside her sick body? Well, okay. These chemoreceptors report to the pons. If you'll remember from our anatomy lecture the other day when we talked about the brain, we talked about the pons being the center for respiratory control. So how fast and deep you breathe is established by something in your brain stem called the pons, P-O-N-S. And the pons tells you how fast and how deep to breathe. Now, us in here today, our stimulus to breathe, do you guys remember the normal stimulus to breathe? Like we are right now? Is the CO2 level. We talked about the free diver, remember? What makes you breathe faster and deeper? CO2 levels climb up. We breathe fast and deep, we get rid of the CO2, we come back to a more normal, relaxed state. Okay? When you go run a mile, you breathe faster and deeper. Why? CO2 levels have went up because you've increased metabolism. No problem there, right? Miss Margaret, do you think she has high CO2 levels? Do you think she always has high CO2 levels? Why? Because it's chronic. The human body is fascinating. The pond says, you're continuously reporting high CO2 levels to me, and we have turned up the breathing as fast and as deep as this individual can stand. And the body says, yeah, I know, we are tiring. We are wearing out trying to maintain this. And the body says, well, let's go to plan B. The pond says, no longer will I use CO2. I will convert over to something called hypoxic drive. And now the stimulus to breathe is going to be O2 levels. So Miss Margaret's stimulus to breathe now is the level of oxygen in her blood, not the level of CO2 in her blood. We say now that this patient is running on hypoxic drive. What causes you to breathe? O2 levels falling. What makes her breathe? O2 levels falling. What's this one magic green gas that every EMT and paramedic has in their ambulance? They just love to give it to people. Oxygen. Ma'am, you're having trouble breathing? Let me give you some oxygen. So let me give her oxygen indiscriminately, just because. When I say indiscriminately, that's what I see everybody else do. Let's give her some oxygen. So her stimulus to breathe is the level of oxygen in her blood. And if I artificially inflate the level of oxygen in her blood, what happens to her stimulus to breathe? It goes down. So I could give her a whole lot of oxygen and turn around and look and she's not breathing anymore. Who did it? You did it. Let me caution you about something. That is not a reason to withhold oxygen from her. If she needs it, she needs it. If I give it to her and her breathing rate gets too slow, can I breathe for her? Yes, I have a tool in the toolbox that I will breathe for her. She's hypoxic And I can't give her the drug that fixes hypoxia because she might not breathe if I give her that damn drug. Lady, you got yourself in a bind. The medicine you need, oxygen is a medicine, the medicine you need will also stop your breathing. It takes a little time though, okay? Don't think you can just wave the mask and she goes out. It takes a little time. The higher the concentration, the less time it will take. Always be alert for their breathing rate, because once you put them on oxygen, you need to know in the back of your mind, you're kind of tricking the pawns into thinking things are good when they're not. Always monitor the patient you're giving a medicine to. Even something as simple, if you want to say it's simple, as oxygen. If I say this, there may be some of you who go, this guy's absolutely nuts and I'm not listening to him anymore. I honestly feel that one of the most dangerous things in your ambulance is oxygen. I think maybe one of the most dangerous drugs in your ambulance is oxygen. And it's often the drug that we give without thought, warrant, or any speculation. We just go, got a patient, got to give them oxygen. I've got seasoned paramedics out there who tell me, it's just oxygen, we got it around us all. We got it at 21%, we don't have it at 100. What happens if you give oxygen to someone who doesn't need it? You increase the risk of oxidative injury. Oxygen's not just safe. It has some risk, and we need to stop that. So here's how I would know if I need to give Miss Margaret some oxygen. One question, is her pulse oximetry 94 or better? If I put the pulse ox on her finger and it gives me a little number, I guess I should go over there to Gus's board and show you how pulse ox works, huh? Amber, this is why I can't go in order. Because where are you going to find out how pulse ox work? Well, that's in the other chapter, okay? So it's just all better here. So Sterrett, you're sitting here with Miss Margaret. Are you going to sit down and start touching her and measuring vital signs and getting an assessment on her?
Will you tell her what you're doing and ask for permission?
Sure. Yeah. And she'd probably be more than glad for you to help break this exacerbation. Jonah and Jordan, inside the hospital, you go in and you just stick the pulse ox on them. It's just a little clamp device that goes on their finger. And if I can draw that clamp device, I'm going to do it very crudely here. It kind of hinges and it goes on the finger, and her fingernail's under here, okay? You kind of with me on that? Looks like a Pac-Man, doesn't it? So what's happening is there is a transmitter here and a transmitter here, and there's also a receiver here and a receiver here. The transmitter is shining both visible red and infrared light. Okay, it's shining. If you look at those pulse ox, you'll see the little red light going up in there, and that's the visible red because I can see it. There's also infrared that I can't see, and it's pushing those beams of light toward the other side of the clamp. Kind of with me? And we'll play with those Thursday. Just clamps on the finger, shines through the fingernail. What if they got fingernail polish on? Won't work. It won't work. And coming through the fingernail bed, every time the heart contracts, is a red blood cell, isn't it? Or some red blood cells. And that light hits that red blood cell. Depending on how saturated that hemoglobin is with oxygen, this computer determines by how much light is bounced back to give me a percentage of saturation. It's pretty cool, isn't it?
What if
I got two questions out here. Yes, go ahead. No, you're fine.
when respiratory failure or respiratory arrest happens and their BP drops and they're no longer perfusing?
That's the limitation of the pulse oximeter.
So what would you look at to determine they're getting enough oxygen?
At that point, I know you're not. Okay?
So you intubate them. Then how do you know?
At that point, I know you're not. I got a better tool, and I'll talk about that in a minute. So I'm going to, no, it's cool. I love the question because it segues into the next one. Yes?
Maybe a dumb question, but could you put it on a toe?
You could put it on toe. You can put it on an earlobe. Anything thin enough to shine it off. So you guys are already identifying limitations to this. I gave you one, which says fingernail polish. Jonah gave you another one that says, what if I'm not perfusing there? Hey, if I'm not pumping red blood cells by there, I'm going to get a false reading. Huckabee gives us another example. Maybe I need to go more to the central point of the body. Maybe an earlobe. I'm going to show you a better tool here in a little bit.
So, like Apple Watches or some fitness trackers.
Ah,
they
hell
do
with
that.
them.
So, they don't work?
It's still going to have limitations.
Mm-hmm.
Hair, sweat, conductivity. Is it touching? Did it fall off to the side? Even these fluorescent lights will mess them up because there is infrared coming from these. Bright sunlight outside will change it. If you want to be really accurate, you need a blanket over the top of it so no outside light can hit that sensor. Jonah, if I may, this is the worst damn tool invented.
Yeah, I hate this stuff.
This is the worst damn tool invented. It's great technology. It's awesome in how it works.
But they never work.
But the user, COVID was a great example of this. I had a mother-in-law call me, a mother-in-law, like I got more than one. Maybe I just categorized that, right? My mother-in-law would call during COVID because pulse ox, I mean, everybody was buying a pulse ox, right? And if your oxygen saturations, COVID's really affecting you. And it's like they were old people and they sit around, they measure their pulse ox all the time. Where I'm sitting there going, how many beers did I drink? And how many are left? Do I need to make a beer run? They're measuring pulse ox on each other. And she would call and say, this morning it was 96 and I just took it and it was 95. Do you think I need to go to the hospital? No, you need to throw the pulse ox in the trash. But we had lay people with these pulse ox. Hell, trained healthcare professionals don't use them correctly and often don't understand the limitations behind them. Is it great technology? Absolutely. Is it the best guess scenario? Absolutely. Do I need to understand the limitations of the device? Absolutely. And I think the biggest one, Jonah, is what you were bringing up. If I've already got a poor perfusing patient, this goes back to what we were talking about, Amber. People just want to look at the machines to give them the answers. We can't do that. You work in a hospital, you got nurses that are doing more typing than touching patients. They walk around with their carts and that's all they do. They're like robots in there and it drives me insane. When my mother was in the hospital, that was the first time I'd been in that ER in over 10 years. And then I got to really watching closely how EMS is bringing people in, which was over 20 years for me to do that. It is not the same and it is not better. People are looking to these machines to give them the answers, just like my mother-in-law was looking for the machine to say, am I in bad shape or not? And when I treat a patient based on blood pressure, we saw the dangers of that yesterday. When I treat based on the pulse oximeter alone, we see the dangers of that, don't we? I told you I can take a man in the funeral home, non-embalmed. He has to be non-embalmed because he's still got to have blood in him. But I can make his pulse ox great. I can make him pink. Is he alive? No. No. Do I expect Miss Margaret's pulse oximetry to be low? Yes. Am I ever going to get it to 94? No. And if I crank up the oxygen trying to reach 94, what have I done to her stimulus to breathe? I've lowered it, at least lowered it. Maybe you should ask yourself this. is Miss Margaret suffering from not enough oxygen in the room?
No.
She's got just as much as I do. Now, unless you find her locked up in an RV with a generator running, that's a different story. That's a toxicology lecture. It's not too early to say this. Did I tell you oxygen and hemoglobin love each other? Well, hemoglobin and CO, which stands for carbon monoxide, do not confuse that with the other molecule that's very similar, carbon dioxide. That's CO2. We've said that so much in this class. I'm talking about CO, things that are a byproduct of combustion from a gasoline, diesel engine, stuff like that. Wood-burning stoves, anything that burns carbon can generate CO. Well, CO loves hemoglobin times 200. Another way to look at that, if I had 200 oxygen molecules and one hemoglobin, and I had one CO molecule, I'll take you before I take 200, any one of those. Hemoglobin and CO love each other 200 times stronger than than hemoglobin and oxygen. Limitation of the pulse oximeter. If the carbon monoxide will saturate the red blood cell and make them pink, this pulse ox will give you a reading of 100%. So if I take someone who's been exposed to carbon monoxide, the pulse oximetry reading is false, even though it's good. When those first came out, I was in a refresher course with a bunch of paramedics, and it's new technology. That's how old I am. I predate the pulse ox. We got pulse ox, and everybody's like, hell, this thing's cool. It'll tell us how well they're doing. And a bunch of guys who smoked would go outside and let me see what smoking does to this. And they'd put it on their finger and like, I'll be damned. I told you smoking was good for you. You're just 90. You're just 95. You little old weakling. Come out here and smoke a cigarette and get it to 100 like me. What was happening? Carbon monoxide was building up. And if carbon monoxide is what's saturating your red blood cell, what's not on that red blood cell? O2. So your patient's actually suffocating at the cellular level, and it takes 200 times longer to disassociate. So once it gets on it, they stay together for a really long time. Pulse ox, useless, unless you want to confirm CO poisoning. If you've been locked up in a camper trailer with a generator running and I put a pulse ox on you, I expect to see 100. That may be one instance, or unconscious and near death would be the better one. Treat the patient, not the monitor. Yes?
I do have a question. So with a patient like this, when it comes to medication, would you give her like a higher dose of whatever's in her inhaler?
Great question. Great question, and right on target, Starrett. So at least you and I are going well, and the rest of you who have questions, please ask, okay? Because that's kind of your quiz. That's kind of your test. Hang on. So she has the same access to oxygen that I do. So she obviously doesn't have an oxygen atmosphere problem. What does she have? And that's going to get to your question. What problem does she have? Well, it depends on her COPD disease. Either she's got chronically inflamed bronchial trees, or she has alveolar destruction. Let's get those two disease processes out right quick. May I? So under the heading of COPD, guys, under the heading of COPD, we have emphysema, and think alveoli destruction. What is emphysema? Alveolar destruction. What is emphysema? Alveolar destruction. Altogether, like Simon says, emphysema is alveolar destruction. More dead space. Chronic bronchitis. So medical terminology here. Chronic means forever, long term. Bronch means the bronchial tree. Itis means inflammation of, swelling of. So her bronchial tree is constricted down because it's inflamed. Sterrett, what type of medication do you think she probably has been prescribed?
So that's what I was about to ask you. I forgot
I know.
the difference between
I know.
beta and
Okay. No, great, Sterrett. Let me ask somebody else. Christian, what type of medication do you think she has been prescribed?
I don't know.
Well, she's got chronic bronchitis. Go ahead.
Beta 2 blockers.
He says beta 2, and he's almost correct. He's correct that much. Beta 2, not blockers, enhancers. I got a better name for it, okay? Even though your name's cool, I know exactly what you're talking about. We just got to mess things up in medicine because we can. We got to make this shit hard, even though it's not hard, right? You know what you pay me to do?
Teach me. Tell me what's right.
Make the hard shit easy shit. Okay. Beta 2 enhancers, I love it. I mean, that everybody understands what we're talking about there, don't we? Beta 2 enhancers. In medicine, we call them agonists. A beta 2 agonist. How many of you have little brothers or sisters? Billy, you do?
I mean, he's like 2 years younger than me, too.
Did you ever pick on him
Yeah.
when you were younger? Did you ever pick on him to the point where he'd get in trouble so you would not? Did your mother ever come to you and say, quit egging him on? And she might have said quit egging him on, which is not correct, but quit egging him on. That's how I remember that. An agonist aggravates, an agonist brings it out in him. An agonist is bringing out whatever word's in front of it. Help me with your name again.
Nate.
James?
Nate.
Nate. Nate, glad. It's the first time you spoke up. And I love it. Nate, whatever word you put on front of that, if I say beta 1 agonist, what do we know? It's going to do what?
Helping it.
It's helping the heart. What's the opposite of agonist? Antagonist. An ant. If I ant something, I'll do away with. Antagonist. This really gets funny when you're editing textbooks or writing test questions and you have an English major in the room. They're looking at characters in a story. I'm not looking at characters in the story, but it's kind of the same thing. So we expect Sterrett, we expect Nate, her to be prescribed a beta 2 agonist. Kristen, do you happen to know a name of one of them? There's a bunch of them out there. I'll just throw one down that's pretty common. Albuterol. Albuterol.
Zopanex.
Zopanex. It's in there too. And that's an albuterol combined with, that'd be Duoneb. Zopanex is kind of like the high class beta 2 agonist. It's expensive as hell. We don't carry it on the ambulance because of the cost, but it's effective. But back to the point of the scenario we have on the board, she's taking a beta 2 agonist routinely to try to open the bronchial tree. What other class of drugs gets rid of swelling? Because we got some swelling here. Do what? Steroids. Not the kind to go whoa with, but the non-steroidal anti-inflammatories. Well, actually it is a steroidal, so it's not the anabolic. So you could say the corticosteroids. The corticosteroids. She's taking steroids, not anabolic, cortico. Corticosteroids are related to a stress hormone in the body called cortisol.
That does the same thing as
by a different avenue. It's got the same desired result by different mechanisms. You get the same desired result by different mechanisms. A beta-2 agonist like albuterol is fast on, fast off. It's kind of like the rescue inhaler. The corticosteroids, slow on, slow off. They stay with you. So we're still looking at Miss Margaret, and Sterrett has all this information going on in his head. He expects her to be taking these drugs, so he's going to look at her med history to see if he's right. And if he's right, and he sees her taking something like Solumedrol or some other form of corticosteroid, that is not good for the body. Long-term use of corticosteroids is not good for the body. One of the major things it does is it lowers your immunity. So Sterrett, Miss Margaret at 62 years old has lowered immunity, and you just walked in because you're too stubborn to call in sick, but you've been suffering from the flu.
I'm gonna tell Luke to do it.
Yeah, Luke, go in there, Luke. I got the flu. And that's just a point for me to say, you guys are sick, stay home, because you're going to encounter patients with weakened immunity. The other thing is she's more susceptible to infections. So I'm already looking beyond her COPD and going, Margaret, let me listen to your lungs for a moment. And I'm now listening for, is there signs of pneumonia? Because I have to keep in the back of my mind, maybe it's the pneumonia that called me out here today, not the COPD. I don't know, but I know she's taking that and she's prone to it. I don't know. So I have to look for it, right? Make sense? She is using a nebulizer and a portable oxygen concentrator. So she has one of those little machines at her house that goes bzzz, like a fish aquarium pump, just bzzz, it buzzes all the time. Be good white noise when you sleep, wouldn't it? Bzzz. So it's concentrating oxygen and it's delivering that oxygen to her probably through a nasal cannula. You don't find them that can concentrate fast enough to run the big mask. It's usually just a nasal cannula. Plus, we don't want to give her a whole lot of oxygen, do we? Because she's already on hypoxic drive. And she takes a nebulizer. What is a nebulizer?
It nebulizes the albuterol.
Okay. The nebulizer is a container, and we're going to play with one of them Thursday. It's got oxygen tubing going in it, and you pour the liquid medication in it, and you turn on the oxygen or the air, basically just compressed gas is what you're doing. And it makes this medicine nebulize or turn into a mist.
Those are fun.
Huh?
Those are fun.
Are they fun?
Yeah.
What are you misting? Never mind.
No, I'm kidding. No, I use one. I got lung or water in my lungs.
Okay.
It sucked, but
It helps, doesn't it?
Yeah.
And they make a little noise. You'll hear the air running through there. That's pretty good, actually. And it'll mist this stuff like a fog, and we're inhaling that, or you hope the patient's inhaling that, and you hope it's reaching what we call the target organ, which in this case is the bronchial tree, and because it's a beta-2 agonist, it's going to open up that bronchial tree and it should relieve her breathing. Now the 21% oxygen that's already available can start reaching the alveolar space, not the dead space. Here's a problem with this. If her tidal volume is so shallow that she only moves the medicine to here, is it going to work? Not very effectively. And so the paramedic, if this patient doesn't improve, you could call the paramedics out to the scene, and we have a medication that we can give them in the IV that will go reach the target organ through the bloodstream and open up the bronchial tree. Miss Margaret just got complicated, didn't she? Now, the majority of people would say, put her on oxygen and take her to the hospital. Give her a nebulizer if you have one. We've got a lot to think about here. Nate, you said that was a beta-2 agonist, so that's a sympathomimetic. What part of the nervous system do we find betas? Sympathetic? sympathomimetic. What's the word mimetic mean? Looks like. So this drug is also classified as a sympathomimetic. Amber, this is why we're not lecturing on the pharmacology chapter, because we're doing it. Sympathomimetic. This drug looks like what the sympathetic nervous system looks like when it's activated. What if I change the word mimetic to lytic? What do you think would happen?
The opposite.
It'd be the opposite. It'd get rid of it, wouldn't it? You really don't see a lot of sympatholytics, but they do exist. You're more likely to see a parasympatholytic or a parasympathomimetic. Do what? Or an anxiolytic, yes. You guys are learning quick. I'm very, very pleased and impressed. Good job. Good job. So that's a sympathomimetic. You say it's beta 2. Do you think there might be some side effects of beta 1 and some other stuff going on? I mean, it's not pure beta like epi, but there probably is a little bit of beta 1 going on. And when it's beta 1, what do you think's happening, Cass? What do you think's happening since there's some beta 1 side effects kind of happening? If the beta 2 is working on the lungs, the beta 1's going to affect the, that's alpha 1, the heart. Going to increase the heart rate, going to increase contractility. What if old Miss Margaret also has a history of cardiac disease? Which she probably does because she's got a history of respiratory disease.
Cardioverter.
Shock the shit out of her, yeah. So when I give her a beta 2 agonist like albuterol, which is targeting that, but I know there's still some side effects to the heart, could I bring on like cardiac MI kind of stuff, heart attack kind of stuff just by the administration of that drug? Could. It's something to be aware of. Something to be aware of. So it really gets complicated if she's having this and associated chest pain. Thanks, Margaret. If she has associated chest pain and shortness of breath, let me just go ahead and kind of tease you a little bit. When you have a heart attack, oftentimes the number one symptom is shortness of breath. When you have an exacerbation of COPD, often the number one complaint is shortness of breath. Can you have COPD and heart disease? You likely do. Can you have heart disease and COPD? You likely do. Can the medication for this cause problems with this? Yes, it can. Can I worsen a heart attack by giving albuterol? Yes, I can. Yeah. Well, I'll save that for the paramedics.
Why does it worsen again?
Because when I give a sympathomimetic like a beta 2 agonist, we really call those, Nate, beta 2 selective. I mean, the chemical compound in albuterol is really meant to go, I'm going to work on the 2 lungs, kind of leave everything else alone. Okay? If I was to give Miss Margaret epi, say I nebulized epinephrine, I'm going to get just as much heart as I'm going to get lung, as I'm going to get alpha 1. Does that make sense? And so we don't necessarily want to raise her heart, so we're going to use a beta 2 selective. But even with that, there is still some bleed over to the heart. There is still some side effects that affect the heart. And if she's already got a weak, damaged heart, this may actually worsen it. Therefore, albuterol is not in your bag of tricks at the EMT level. We can assist her with her prescribed nebulizer or inhaler, but we don't pull one out of our bag of tricks at the EMT level. We save that for the paramedics. because the paramedic is also going to do a 12-lead EKG on her to see if the heart's suffering right now or not, and do a risk-benefit analysis. You with me on that? We will not give her albuterol from our bag. We will only assist her with her own rescue inhaler. So Sterrett, you'll be looking at her going, have you used your nebulizer? If she's used it 5 times with no relief, some things you got to look at there as well. Is it good? Is it in date? Did you use it correctly? Or maybe it's time to call more advanced personnel in to work at her. Oxygen concentrator, I'm not worried about that thing. It's not the root of the problem. It may help her a little bit. It may keep her just enough so she's not like severely hypoxic, but it's not the cure. Neither is the albuterol. Neither are the corticosteroids. What's the cure? Huh? There's not one. There's not one. The best I can do, Margaret, is just get you through this. I can't make you well.
Lung transplant?
Nah, they're not gonna waste long on that.
Well, no, you can't because it's contract. Well, you can if it's chronic bronchitis. You can't.
Yeah, but I mean, what else has she got? You know, you gotta look at all that too. And what, like I said before when we led into this, if she's still smoking, if you make her put the cigarette out to assess her, you get really aggravated. Guys, I'm not exaggerating. These are some of these homes you'll go into and you'll look at the calendar and you go, 1964? This calendar's been hanging on the wall since 1964? I dare you to scoot it over. The wall will be white and you thought it was painted brown. These people who smoke all the time, their fingernails will be brown from holding the cigarette. If they got facial hair and it's gray, but it won't be gray right here, it'll be dark brown from exhaling the smoke. They reek of it. They reek of it. It's horrible. And then the lung cancers go up with this use of smoking. Back in the old TMC, they used to have if you wanted to smoke, you had to go out to this little gazebo-looking thing. And staff, doctors, patients. It was so funny to me to watch nurses, physicians, and patients all gather up in the butt hut to smoke. But you go back 60, 70, 80 years, 9 out of 10 doctors recommend Camel cigarettes for good health. Even in the 70s, you go into a doctor's office, they would often set their cigarette down in the ashtray while they listened to your lungs. It was recommended by the American Medical Association.
I'm curious, what's the difference in side effects from smoking and vaping?
A lot of different compounds. You don't get the tar, but you get all the chemicals from the oils that are being nebulized, and we know those oils aren't good to eat. They can't be good to smoke either, bring into your lungs. So the risk factors are probably just the same, but vaping's so new we don't know the long-term effects of it. But we do know that it's an oil-based, that you're nebulizing seed oils as a carrier for the nicotine or whatever else you want in it. Yeah, probably just as bad, maybe even worse. We just don't know yet. It's not the nicotine that's causing the cancer, it's the byproducts of the combustion that cause the cancer. I've seen people with chemotherapy being ran in their arms through IVs who still go to the butt hut to smoke. I guess at that point, what's it matter? What's it matter? Smoking's, well, you talk about the 4 horsemen? It's the one feeding all the horses. Okay, it's really out there in a bad way. So you know what she looks like. Can I have that back? You're like, no, I don't know if I want to give it to you or not. So, Sterrett, just some simple questions. What is your general impression of this patient so far? Before you answer that, here we go again. So when I look at a patient from 30 foot across the room, and everybody needs to be very aware of this, when I'm looking at her as I walk into the house, sometimes I can tell through dispatch info. Sometimes I have to wait till I see her. But every patient gets this assessment, and it's called the general impression. This is chapter 10, Amber, of patient assessment in the textbook. We just do it as we go, okay? So it's all going to be all right. I ask myself 3 questions. Are they sick? Not yet sick? Not sick? That's called the general impression. Your textbook doesn't do it this way, which I think is a disservice to you. So, once again, I come in here to try to help bridge the gaps. When I look at a patient, I say they're sick, they're not yet sick, or they're not sick. Well, let me preface by saying about 95% of your patients will be not sick. And this is what frustrates the heck out of us in 911 world. You called me for what? You're not sick. You're hungry. Maybe you're just hungry. Maybe you're neglected. Maybe you're lonely. Maybe you ran out of your medication. What? But you're not sick, but yet you call me because we got every piece of equipment we own in fire and EMS that says call 911 on the side. And that's what they do. We told them to. And we instill in our elementary schools, call 911 when you need help. I mean, you need help, 911. Don't get mad when they call you. You told them to. Majority of your patients just aren't sick. Why'd you call me out here tonight? My pulse ox is 95 and I'm afraid I got COVID. You're not sick. Here's another one. You called me out here because you found somebody dead in the bed and they're decomposing. They're not sick. Right? So what is not yet sick? That's the kind of person you'll look at and go, you know, if you don't get some help, Murphy's Law is going to apply and things are going to go from bad to worse. I don't know when that's going to, it may take 5 minutes, it may take 5 days, but you need intervention or you're going to become the worst one, and that's sick. Are we making sense? What's a sick patient? A sick patient is somebody who I have to intervene in now or they're going to die. Like now. Like it's life-threatening, urgent now. So a person who has a complete airway obstruction because they choked on a piece of steak. It has totally sealed their airway off. They cannot move air. And they're passed out on the floor, blue. What are they? Sick. If I take a diabetic patient whose blood sugar is 500, what are they? Not yet sick. As long as they're talking to me and saying, I'm just weak, I don't feel well, my skin's dry. You need to get that fixed. But yes, Derek?
So then someone with like chronic bronchitis or COPD is sick. Because that's chronic and that means it will lead to.
Yeah, today during the exacerbation of it, they're probably sick. If they're not having an exacerbation of it, they're ill. Yeah, of course they're ill. They got a disease, but they're not yet sick. But you can't fix that one either. So that's kind of a special case. But I'm forming my general impression of this patient. Since this is your patient, I guess that would be a good thing for you to ask. So rate her.
Sick.
Can you change your mind?
Yeah.
Please be flexible enough to change your mind. I'm looking at her from across the room and I don't think she's sick right now. Does that mean I stop my assessment?
No.
So if I go in to assess her and I find something that would cause her to be immediately life-threatening, can I escalate this back up to sick? Sure you can. Sure you can. Do all patients get an assessment? Yes. This is just my general impression from across the room. Sometimes it doesn't take much assessment at all. If I walk in and there's a 50-year-old man whose wife said he was eating dinner and just collapsed, and I find him with no pulse, unconscious, not breathing. I don't need much assessment, do I?
That's it.
He'll be all right. Does he have a DNR? So that man is obviously sick, and I haven't even touched him yet. Are you with me on this? So that's what we'll do with every patient. We will look at them and go, he's sick. I found myself doing this in the field, and nobody had ever lectured this to me. And what you end up doing is you and your partner, you arrive on scene, you look at somebody and you go, hey, we got to go. We ain't jacking around here. What were we really saying?
They're sick.
They're sick. They're sick. Not that I want to get off in that because it's a sticky subject. If lights and siren are anywhere here, it's up here. If they're anywhere. So I'm not a big lights and sirens fan, I already told you. So what do you think about Margaret now?
So I forgot, in the actual call, did they say she's a COPD patient or not yet? Was that actually?
No.
No, slide it to again? Okay.
No, you determine that. Why? Barrel chested,
Yeah.
nebulizer,
Yeah.
portable oxygen.
Yeah. So she's probably a COPD patient. She's actively exhaling, and her skin is pink, so she's probably hypoxic in some way. So she's classified as a sick patient.
Okay.
And then with do I just go through the questions real quick?
Sure.
All right.
What additional information will help you complete your general impression?
Additional information, I'll ask her about medical history, things that can help with that. And then medication.
I keep on reading.
Okay. No one more we're looking for?
I'll give
Mother hurt.
Jordan,
What's the main?
I'll give you a word for this. I'll give you a way to do what you're doing. You had to know this anyway, okay? Amber, it's out of chapter 10. Sample. So stare it. I'm going to gather a sample history. S-A-M-P-L-E, sample. So a sample history looks like this. The S stands for signs and symptoms. So what is a sign? Something I can measure. What is a symptom? Something they tell me. What is a sign? Something I can measure. What is a symptom? Something they tell me. The A stands for allergies. So you're going to ask Margaret, you don't have to ask in this order. Now please understand that. But you can you can have a conversation and acquire this. I can always tell a new EMT from an experienced one. An experienced one sits down and has a Coke with them and gathers all this, kind of like, hey, I got it all now. But a new rookie EMT or paramedic will go, I'm going to gather your sample history now, okay? What are your signs and symptoms? She's like, what? I can't even talk. A stands for allergies. And what I'm looking for here is I'm not allergic to poison ivy. I don't care that you're allergic to poison ivy unless that's why you're calling me. I care about a drug that you take that causes you to go into anaphylaxis. And we'll discuss anaphylaxis later. And I always get this, and when you get these medications, if she says she's allergic to penicillin, I'm writing that down, no problem. And the abbreviation for penicillin, by the way, is PCN. So I don't even have to spell it, just write PCN, that's penicillin. Okay, I'm not gonna ask. But if she says, I'm allergic to Benadryl, actually, that's a drug I will give you if you're allergic to something else. So I just ask you more questions, Miss Margaret. What does Benadryl do to you that causes you to be allergic? It makes me so sleepy. I'm allergic to morphine. Okay, what's morphine do to you? It knocks me out. Doesn't cause you to break out in hives, put you in ICU on a ventilator. Don't think so. we'll talk more about this later, but most allergies come from something that has a protein in it. Most of it comes from stuff that has a protein in it. I will write down whatever she tells me, but I also take it with a grain of salt. If she tells me albuterol makes me nervous, Valium makes me so sleep, don't confuse side effects with allergies. The M stands for medications. What medications are you taking? It's not a bad idea to ask about supplements because supplements are such a big deal anymore. People do not trust the healthcare system and they go self-supplement out of the Walmart supplement aisle. Some of those are within reason. Some of those you're really hurting yourself. The P stands for past medical history. You're basically getting a med history. Had a heart attack 3 years ago, got diagnosed with lung cancer last year, I've got type 2 diabetes, I have a stomach ulcer, I have Crohn's disease. That could all be in the same patient, by the way. It's not uncommon to have those multiple comorbidity factors. The L stands for last oral intake. Last oral intake. That may be very pertinent to the situation at hand, or it may be pertinent to the people who are going to take her to surgery. We just kind of like to know how much stuff she has in the gut. Last oral intake. If she says she had a glass of water last night, probably not near as significant as I just had a half a pizza before I called you. Because if you ever go to intubate someone with half a pizza on board, it's ugly. The E stands for events leading up to the episode. Events leading up to the episode. So what were you doing when the shortness of breath started? I decided I would vacuum the floors, and I just got short of breath. Kind of got a reason. She exerted herself and stuff like that. It really comes into play with chest pain patients. What were you doing before the chest pain started? I was splitting firewood. Okay? You're putting a stressor on the heart. What were you doing when the chest pain started? Oh, I was kicked back in the recliner with a Dr. Pepper and a Twinkie watching The Price is Right. That's much more serious than the splitting the firewood because you just had a heart attack while doing nothing. Some people are very secretive about what they were doing before the episode started. I have picked up many asthma patients who developed an asthma attack during an exercise with their loved one. And they're reluctant to tell you what happened. Like, what's been going on in here? So that's a sample history. Okay? You don't have to gather it all at once, and you kind of gather it on the fly. I like to let the people talk. When I'm asking questions, Starrett and everyone, when I ask someone questions, I ask open-ended questions when possible. I don't want to provide the answer in the question. I bet you were up exercising a lot and your chest pain started, right? Well, as a matter of fact, yeah, I was working. Let them give you the answer. Yes, Gus?
So are you writing all of this down when they say it, if you have the time, or do you just remember it and then in the report later try to write down as much?
Yeah, because I was about to, what if it's a critical situation where it's like, oh, she's telling you her symptoms, but then she just gathering all the stuff that you need, but she just falls over.
Mm-hmm. If I think their ability to answer questions is going to leave me quickly, I will hurry up the interview process. That's not that common, though. Usually when they're still with it, when you get there, they're still with it. we rarely do we find somebody on the brink. They're either fine or they're either sick or not sick. You know what I mean? Do I write it down? Do I try to remember it? You will. I mean, I think you will. If you need to write it down, write it down. Some people write it on the back of their gloves. I know I did, but it's really not. It's really ugly when you pull the glove off and you lay it back out on your counter and you're trying to document the information from your glove. Some people's partner will write this down and make note of it while they're doing the interview process. I carried a small, a little 3x5 notepad in my pocket or in my pocket. I'd flip that out and just jot some notes down on that. It's probably the best. And you can find some really cool ones that actually have reminders on there. It's like, it'll have sample listed and you can just fill that out. It'll have a chart of the body so you can document what you saw. It'll have the blood pressure reading to fill in. So it's kind of like pre-populated for you.
This is random, but could you have like a recorder?
Well, to record someone, they must know that you're being recorded and have their permission. I tried that before. It was a pain in the ass. Of course, I didn't have cell phones. I had a micro cassette recorder, and you'd have to pull it out, and it was like, I'm about to. We do have those abilities on our phone now, but you have to make them aware that they're being recorded. Some services wear the body cams now, but I don't. I'd hate to try to replay all that to get the information back. You'll remember it. Final question, we'll take a break, Sterrett. What immediate action should the EMTs take while completing the primary assessment?
So with this one, is this when it comes to medication, or is this just ending the sample process?
So you're conducting that, or at least portions of it.
So then when it comes to giving like a sort of medication, you said that pulse oxes are crap.
Well, that doesn't mean I won't use it.
Okay, that's what I thought.
It doesn't mean I won't use it.
Yeah.
It just means I will take the reading into context of the environment that's going on. That's what we should do with anything, right? If I give you a blood pressure that's 130/90, you can't say, well, they're not in shock, can you? We learned that yesterday. You have to take it into the context of what's going on. Boy, doesn't that get society in trouble anymore. People take stuff out of context.
Yeah.
That's what I said, but that's not what I meant. Okay?
Yeah.
So pulse ox is crap. Well, it tells you this, but it could be crap or it could be good.
Yeah.
Go ahead.
So, and then, with it at the EMT level, you're allowed to help her with the medication she already has after you've, gained knowledge on if she's used it or not. And then I guess we would not give oxygen because
Depends.
it depends.
What's it depend on?
If it's going to make her stop breathing or not. I guess.
Well, that's the risk of me giving it,
Yeah,
but that's not going to change me giving it or not giving it. So help me with that. Help everybody with that, because that's a great question. That's the only medicine I can give her that's applicable at this moment is oxygen. So there is a judicious judgment call here. Should I or should I not? So I've already given you one clue. If that pulse ox that you call crap is less than 94,
Yeah.
what else?
I say you should.
Based on what?
If I remember, she was breathing too fast and not enough.
Well, yeah, was this one breathing too fast or was this the slow one that you were talking about?
She was fast.
This one was fast. Okay.
Fast, so
Okay.
the oxygen's not having enough time to fuse for its exchange. I can't word it together, but
No, you're fine.
whatever. little-
Talk out loud. That's what it's all
whatever
about.
little Oxygen helps to, actually exchange gas.
Well, it's obviously the gas we want to exchange. But giving her oxygen doesn't get rid of CO2, does it? And we already said she's got just as much access to it as I do. So maybe I'm not worried about her oxygen as much as I am about her ventilation. Remember, I'm wanting to get the oxygen that is available to the target. Is giving her oxygen increasing the odds of doing so? Absolutely. Signs, the answer to your question, Sterrett and Billy, signs of hypoxia. That would be a great segue till after our break. what are the signs of hypoxia? Riley, will you remember that after break? To make me lead with, what are the signs of hypoxia? And it's not always the number, Sterrett. It's not always the number, Billy. It's not always the rate, Billy. Maybe that rate's good enough. Here's an example. If I go out and run a mile and I come back, I probably won't come back if I run a mile. If I go exert myself running and I stop, am I breathing fast?
Yes.
Do I need oxygen?
No.
But you said, but she's breathing fast. The question is the breathing fast compensating or not? And if the answer is no, then maybe supplementing her with oxygen will be okay. I'm not giving it to her just because she's breathing fast. Billy, there are people who will, and that's not accurate. Either known hypoxia or signs of hypoxia. That's the simple answer to your question, Sterrett. Do I give her oxygen? If it's known hypoxia or signs of hypoxia. They can put a CPAP on them, and we'll talk about that more in a little bit. If your CPAP has a BiPAP, the answer is yes. And that's a device that's just going to take some of the workload off of her breathing.
Isn't it also blow the CO2 off?
If you're ventilating her, if she's ventilating better because of it, the CO2 will come out more effectively. And the rest of this may be transport.
Yeah.
Monitor and transport.
So then that's another thing I'm curious about. You talked about how you would put them on the stretcher where they can still be sitting up with their feet on the ground. Would you put them on the stretcher or would you just assist them into the ambulance?
I wouldn't make her walk because that's just going to increase the workload on her O2 demand.
Okay.
So I never make her walk. I will turn the stretcher into a chair. I'll set it up upright.
Okay.
The feet on the floor comes with pulmonary edema, and we'll talk about that later. Position of comfort is a catchphrase, a catch-all phrase for these people. Transport them in position of comfort. But lying her on her back is not going to work.
Yeah.
Jordan, we have a name for difficulty breathing while lying flat. We'll talk more about that a little bit later too. That's called orthopnea. Difficulty breathing while lying flat, orthopnea. Back to chapter 3 now, Amber. I know it's a lot, guys. I know it's a lot. You're doing well. It's Tuesday. And it's break time on Tuesday. You are halfway through the lecture week. Congratulations. So let's come back in at 11 since we went a little long this morning. Give you 15 minutes. And we'll get to the third slide maybe.